welcome to the fourth installment of Continuity Insights podcast series. This series runs each month, appearing first in our monthly digital magazine and later on our website. Information about upcoming podcasts will be made available on the Continuity Insights LinkedIn group or via our weekly CI Bulletin e-newsletter, which you can subscribe to at continuityinsights.com/subscribe. We are now well and truly into flu season, so this month I'm joined by two members of our editorial advisory board with extensive experience in public health to discuss pandemic planning. Dan Hahn is a country emergency manager, adjunct faculty at American Military University, and an instructor at the University of West Florida. Scott Phelps is a professor of disaster science at the Emergency Management Academy and former Assistant Commissioner of Health for Emergency Management at the New York City Department of Health and Mental Hygiene. Both Dan and Scott are also paramedics. Thanks very much for joining me today.
Thank you.
So I'd like to start by asking both of you what the recent pandemics, such as H1N1, have taught us in terms of how businesses should prepare and plan for these events.
Scott, you want to take it first?
One of the things that we've learned is that media hype really drives everybody's response. There is a circular feedback loop where what we're finding is that while most organizations had plans for flu, they were thrown into a tizzy about developing a specific pandemic plan, which is probably not the most efficient way to do things, and for a number of reasons ends up being pretty dysfunctional. And when you cry wolf enough times, nobody is going to listen to you in the future.
There's not a whole lot I could add to that. He pretty much hit it on the head. Everything is driven by the media, and that's a shame. If business continuity managers could have their bosses not watch television and just listen to them, that would be the best way of handling things, but we know that's not a reality.
We received a number of questions from our readers for this podcast. The first one we received asks, since H1N1 was really not the major pandemic many of us had been planning for, how do we deal with quote-unquote pandemic fatigue and emphasize to senior management that there's still a need to plan for pandemics?
Well, I like this question. Very, very accurate, very good question. This is what I would ask them. So how do you prepare for hurricane fatigue or active shooter fatigue or there's a fire in my IT department fatigue or tornado warning fatigue? You just have to deal with it. You have to plan for everything regardless of whether there's a fatigue or not. So do it. And I would refer you back to my first answer about turning off the TV. But honestly, 40% of a company's workforce could potentially be gone during a pandemic. Don't you really want to prepare for that?
I would actually say that we shouldn't be planning for pandemics at all. We should be planning how to spread limited illness in general. So what we need to focus on is becoming a more resilient organization and work on having a culture where we do smart things like focusing people on washing their hands every day, not just during flu season, and getting them to sneeze into their arm rather than into their hand. If we try to plan for pandemics and they don't happen, nobody's going to reinvest the money. If we reduce absenteeism because people don't get sick, whether it's cold season or flu season, whether it's a pandemic or not, we can actually show real return on investment to the organization. The other thing we really need to work on to get better at is to encourage people who are sick to use their sick time. Most companies have a bias against people staying home. So unless we can get over that, we're never going to be able to limit the spread of illness when the organizational culture says that even if you're sick, you should be coming to work. And that just makes more employees sick within a couple of days.
Yeah, that's definitely a mindset change that's needed. For example, where I work, we have a policy, if you have a fever, you're not allowed to come to work until your fever has been gone for 24 hours without medication. In other words, you can't just take Tylenol, make your fever go away, and come to work. If you have a fever, you are not supposed to come to work, and you take that sick leave because we don't want it getting spread.
But Dan, what happens when they're at a sick time?
Well, that becomes an issue.
And that's an issue which has never been resolved by almost any corporation.
That's true. But the fact is, though, what I'm supporting your position by saying that policy, at least where I work, has been reversed, where it's encouraged that you stay home versus encouraging you to come to work regardless. So there's a start.
Right, it's a start. But if they've used up their sick time because they have the flu and they're home for a week and a half, then they're just not going to get paid, which means, frankly, they're going to come to work.
You've both mentioned media hype a couple of times already, and our next reader question touches on H5N1, which I know has been popping up in more and more articles, especially over the last week or two. Their question was, what is the current risk specific to H5N1, which is also known as the bird flu? And if you could start by explaining to our readers, what is the difference between H1N1 and H5N1?
Well, it's the H. There's 16 numbers that follow the H, and the first set, the H, whatever the number is basically how the virus gets into you, and then the N and the 9 numbers that can follow that are, if I'm not mistaken, neuraminidase, and it's more of how it can be processed from me to you, kind of a deal. So the H1N1 and H5N1 are just different by its ability to get into you. Remember that the 1918 flu was an H1N1, highly transmittable, went crazy, and the H1N1 we just had last year was again highly transmittable, but not as much and not nearly as fatal. So I wouldn't concentrate on the numbers. I would concentrate on what the disease does once it affects people.
And how would you quantify the risk of H5N1 spreading here in the U.S.?
It has to get here first. Right now, it's in Asia. In fact, there's on August 29th. I'm going to read this to you. I put this out in a conference last week for a bunch of trauma geeks down here in the Gulf Coast. August 29th, there was an announcement that encouraged heightened readiness and surveillance because of a mutated strain of H5N1, which is highly pathogenic spreading. So there's already been 800 outbreaks of this, and which is more than what's been happening since like 2004, 2008, where there was about 300 a year. So that disease, the H5N1, the bird flu, the avian flu that people were worried about back in 2006, is on the rise. And it's something that should be of concern, especially since its mortality rate is slightly higher than 56%. There was an article that came out, and I sent that to you, a very interesting article yesterday. Bird flu research rattles bioterrorism field. Basically, some scientists made the H5N1 virus with the high mortality rate. They made it so that it was more contagious. Right now, in its natural form, it's not very contagious from human to human. Some scientists went and made it more contagious, and now the bioterrorism field is going nuts, saying don't release that information, because if the good guy scientists can do it, then the bad guy scientists can do it.
But that's always it's a poor argument for science saying we shouldn't talk about it because it's possible. You could genetically mutate polio and a lot of things, smallpox, pretty easily. But at the same time, there's dozens, like you said, dozens and dozens of different strains of flu virus. They appear in Asia. We develop our vaccine for the U.S. based upon the strains that are commonly found in Asia. And then we produce a vaccine. And sometimes the vaccine is great, right on target. And sometimes over the 6 months, 8 months it takes for the flu virus to get here usually, a different strain becomes more predominant. So we have ways to protect against the flu. It's sort of a defense in depth model where, hand washing and vector control against, sneezing and stuff like that is probably the best strategy. Flu vaccination is recommended for all Americans over 6 months of age, and as long as the vaccine strains mirror the strains that actually appear here, we're in pretty good position. But the problem is they don't always match that, and people tend not to get vaccinated.